Welcome to the debate. Today, we are turning our analytical lens toward a deeply complex intersection of public health, sociology, and data science in the Netherlands. We are looking specifically at the health outcomes of Afro-Dutch, African migrant, and Caribbean diaspora communities living in major urban centers, so places like Amsterdam, Rotterdam, The Hague, and Utrecht.
Right. The major hubs.
Exactly. And we're exploring the profound, well-documented biological link between mental health stressors and severe cardiovascular disease risk within these populations. But our discussion today really centers on a fascinating and honestly troubling paradox. Official Dutch health and societal data often suggest a high degree of stability, equity, and integration. Yet these specific Black communities experience ongoing disproportionate psychological stress and immense physical health pressures. So what exactly explains this gap?
And I mean, that is the critical question of this entire subject, isn't it? And it brings us right to our flagship contention today, which is data denial versus lived reality. Are we looking at a fundamental lack of accurate data capture in the Dutch system? Or are we witnessing a systemic cultural failure to recognize the lived experiences of these communities?
And to be clear, we are grounding this discussion in a robust body of source material that includes clinical findings from the massive HELIA study at Amsterdam UMC, qualitative research on the Dutch healthcare system, and deep public health theses on things like social capital, datafication, and ethnic inequalities.
Absolutely.
So for the purpose of our discourse, I will be arguing that this gap is fundamentally a crisis of data denial. My position is that Dutch data infrastructures technologically obscure the realities of these communities, and fixing these statistical systems is the absolute key to preventative health care.
And I will be taking the opposing view. I'll be arguing that the gap is driven by a societal dismissal of lived reality. Essentially, that cultural narratives ignore the physiological toll of daily discrimination, which is something that, frankly, data alone can never fully capture or heal.
That is exactly the dividing line we need to explore. So let's dive right into the core of my position. The central issue we are facing in the Netherlands is a systemic denial of data. Researchers actually use a very specific term for this. They call it colonial aphasia.
Colonial aphasia.
Yes. Think of it as a collective institutional amnesia built right into the state's spreadsheets. If we look at the work analyzing the datafication of race and ethnicity, official state systems like Statistics Netherlands, or CBS, they rely heavily on proxy categories. They use broad homogenizing labels like person with a migration background, or historically, even terms like non-Western alien. They use these umbrella terms instead of precise demographic data.
Which, sounds like a dry administrative issue, but it has massive real-world consequences.
Enormous consequences. It isn't just a benign filing choice. It is a process of technologically mediated racialization. Basically, the state uses technology and broad categories to invisibly strip away a person's specific identity. It effectively erases the specific colonial history and the unique biological and environmental risks facing the Afro-Dutch and Caribbean diaspora.
Right. It flattens the nuance.
Exactly. Think about what it actually does. It takes a highly specific, diverse group of people with unique histories and lumps them into one generic column. When you aggregate an entire diaspora under a label like migration background, you completely obscure the specific alarming rates of cardiovascular risk present in these communities. We know from major clinical initiatives that the interplay between a person's environment and their genetics is crucial. But without granular data tracking this interaction, our public health prevention systems are just flying blind. We can't establish proper clinical guidelines, and we can't implement the early screening protocols desperately needed to protect these communities. The system is failing because the data is intentionally blind.
I see your point, but I come at it from a completely different direction. The core issue isn't merely that the spreadsheets are using the wrong column headers. It is a deeply ingrained race evasiveness within Dutch culture and institutions that fundamentally dismisses the lived experiences of discrimination, regardless of what the data might eventually say.
You think the data wouldn't change the culture?
Not fundamentally, no. The Netherlands has long prided itself on this colorblind myth of tolerance. But this very myth forces Afro-Dutch and migrant communities to navigate systemic racism silently. They are constantly told that racism doesn't exist there. Imagine living in a society that prides itself on being completely tolerant, but you experience subtle and overt exclusion every day. It creates a profound chronic psychological dissonance.
I don't disagree that the stress is real.
But it's more than just stress. As we're going to discuss, that chronic stress directly damages cardiovascular health. We can adjust our data sets all we want, right? We can make our demographic categories perfectly precise. But if healthcare providers continue to view interactions with minority patients through a lens of prejudice, finding them challenging, or presuming cultural incompatibility, the result is going to be exactly the same. Fixing the data infrastructure is just a superficial remedy if the human beings delivering the care remain embedded in a society that refuses to acknowledge the daily toll of xenophobia.
You're bringing up the psychological toll, and I absolutely acknowledge that the stress is a heavy, heavy reality. But I frame it differently. The reason that stress goes unaddressed is a failure of system recognition driven by flawed data models. Let's look at the actual mechanisms the state uses to measure societal well-being and risk. Take systems like the crime anticipation system or the leaf barometer.
Oh, the leaf barometer? Which is the tool the government uses to measure the livability of different neighborhoods?
Exactly. These systems prioritize operational efficiency and property values over equitable human measurement. Because the state relies on those aggregated migration labels we just discussed, the specific mental health burdens facing Afro-Dutch communities remain completely hidden from public health interventions. The state's algorithms strip away the context. They might identify a neighborhood in Rotterdam as high risk or low livability based on aggregated ethnic data and income levels, but they fail to capture the structural inequalities and the specific mental health crises occurring within those populations.
Because the algorithm is too blunt.
Right. The algorithm sees a drop in livability, but it doesn't see a community suffering from targeted generational stress. The stress is rendered invisible because our data infrastructure refuses to accurately measure it. And let's be pragmatic here. If you don't measure a problem, a government won't fund the solution.
Okay, but the stress isn't just invisible to algorithms. It's actively ignored by the culture. Let's translate this into the sociological data on mental health and social capital. If you look at Becke-Velu's research on the European Social Survey data, it finds a huge spike in depressive symptoms among ethnic minorities in the Netherlands compared to the native Dutch population. And what's really crucial here is that about 19% of this disparity comes down to what sociologists call lower structural and cognitive social capital.
Meaning a lack of social networks and community cohesion.
Yes, precisely. We are basically talking about a lack of community safety nets. It's feeling disconnected, isolated, lacking social participation. You cannot capture the pain of that isolation in a standard algorithm. Take the qualitative research on Amsterdam Black women by Ariana Rose. This case study perfectly illustrates the real-world impact of the Dutch colorblind myth.
The one about alternative spaces?
Yes, her research describes how Black women in Amsterdam literally have to carve out hidden alternative spaces just for healing and truth-telling. They have to do this because mainstream society demands they accept their marginalization silently. They use these private spaces for venting and joking just to survive the mental burden of unacknowledged discrimination. No algorithm change, no new column in a database is going to magically generate that missing social capital or heal the trauma of being told your experiences of racism are invalid.
Look, I hear the frustration in that, but why do those communities lack that structural social capital in the first place? The reason they are isolated is precisely because the state does not recognize their specific demographic and health needs, which translates directly to a lack of targeted resources. If the data properly identified these communities, city planners and public health officials would be mandated to fund community centers, targeted mental health outreach, culturally specific support networks.
Funding helps, sure, but it doesn't cure the societal attitude.
But it provides the infrastructure to fight it. But let's pivot from the psychological burden to the empirical reality of how this unmeasured stress manifests biologically, because this is where the data gap becomes a literal matter of life and death. The stress doesn't just stay in someone's head, it attacks the cardiovascular system.
Oh, The physiological toll is undeniable.
It is staggering. If we look at the Helios study conducted by Amsterdam UMC, which analyzed over 25,000 residents, it is a massive wake-up call. Dr. Bert-Jan Vandenborn's research shows that in the Netherlands, African Surinamese and Guinean men have a 2 to 3 times higher risk of hypertension compared to those of Dutch origin. For African women, hypertension is 5 to 10 times more common.
Those numbers are terrifying.
We are looking at a profound cardiovascular crisis. And Vandenborn explicitly notes that this is partially explained by a complex combination of environmental factors and DNA. If we do not have accurate data to study this exact interplay between environment and genetics, we cannot understand the biological pathways. We need technologically precise data, completely free from colonial aphasia, to identify who is at risk and to deploy medical resources effectively. We need to know who is susceptible before the stroke happens.
I agree completely with the severity of the Helios data. The hypertension disparities are, frankly, a crisis. But we have to be incredibly careful about leaning too heavily into biological explanations. I reject any implication of biological determinism here. You mentioned the interplay of environment and DNA, but we must unpack what that environment actually entails for these communities. These cardiovascular outcomes are the direct physical manifestation of the xenophobia and structural exclusion we were just discussing.
So you're saying the environment is the primary driver over genetics?
I'm saying the environment is actively causing the biological breakdown. Public health scholarship on racism in Europe highlights a shift toward neo-racism. Because of the European blindness to traditional overt biological racism, discrimination now operates on presumed cultural incompatibility or nationality. It is a subtle, pervasive exclusion. It's being followed in a store. It's having your resume thrown out because of your name. It's the daily microaggressions in the workplace.
Which causes chronic stress.
Exactly. It keeps marginalized communities in a perpetual state of hypervigilance. Think about what it does to a person's body to constantly be on edge. We know medically that chronic psychological stress leads to chronic inflammation, metabolic syndrome, and ultimately severe cardiovascular diseases like hypertension and stroke. The elevated blood pressure in the African Surinamese and Ghanaian communities isn't just a genetic quirk interacting with a neutral environment. It is biological weathering. It's the physiological wear and tear of navigating a society that treats you as a non-Western alien. The data simply shows us the result, but the lived experience is the actual cause.
I don't disagree that environmental stress causes inflammation. That's a medical fact. But focusing entirely on the cultural cause drastically underestimates the power of data-driven clinical intervention to save lives right now. We cannot wait to cure society of neo-racism before we treat the hypertension. Let's look at how data directly informs prevention, clinical guidelines, and ultimately patient protection. The Helios study didn't just publish a paper pointing out disparities, it successfully changed national screening guidelines.
Which is a positive step, absolutely.
It is a massive systemic step. Professor Charles Adjemang and his colleagues proved through rigorous data that ethnic minorities face diseases like diabetes, which is intimately linked to cardiovascular risk at much younger ages. Because of this undeniable empirical data, Dutch doctors are now mandated to screen for type 2 diabetes at age 35 for people of South Asian descent and at age 45 for those with African, Turkish, or Moroccan backgrounds.
I'm not denying the value of early screening.
Silent risks before they become fatal. It bypasses the subjective biases of individual doctors by mandating care based on precise demographic risk factors. The doctor doesn't have to fully understand the cultural weight of neo-racism. They just have to follow the data-driven mandate to screen the patient. That is why I argue that early screening driven by culturally responsive, precise data collection is the absolute most effective form of community protection we have.
I hear you on the screening mandates, I really do. But if we stop there, we are missing the reality of the clinical encounter. Let me ask you this. You're talking about screening at 45. That's great. But what happens when that 45-year-old takes their prescription, walks out of the clinic, and feels completely alienated by the system that just diagnosed them? Changing clinical guidelines on a national level is only half the battle if the healthcare system itself fundamentally alienates the patient in the consultation room.
But the screening at least initiates the care. It gets them into the system.
But does it keep them there? Let's look at the extensive research by Louise von Uffelen on ethnic inequalities in cardiovascular disease prognosis. Her work using the ACMEA Health database reveals a critical, devastating failure in the system. Ethnic minority groups have significantly higher quitting rates for prescribed cardiovascular drugs such as blood pressure and lipid-lowering medications compared to the ethnic Dutch population. They are getting diagnosed, they are getting the pills, and they are stopping the treatment.
Doesn't that just point to a need for better data tracking on medication adherence? If we know they are dropping off, we can use data to target educational outreach and improve health literacy?
Come on, how does a new column in a database fix a doctor looking at a patient and fundamentally not understanding them? This isn't just an individual failure of a patient forgetting to take their pills, and it's not just a lack of an educational pamphlet. It is a symptom of linguistic barriers, differing health beliefs, and deeply rooted qualitative issues where doctors fail to establish mutual understanding with marginalized patients.
You're referring to the qualitative studies on provider attitudes.
Yes, qualitative phenomenology studies in the Netherlands show that healthcare workers frequently describe their interactions with ethnic minorities as challenging. Think about that word, challenging. This results in less frequent follow-ups and poorer quality of care. If a patient feels judged, misunderstood, or subjected to implicit bias by their cardiologist or their GP, they are not going to adhere to a lifelong medication regimen. You cannot mandate trust through a clinical guideline. The data shows us they are quitting the drugs. But it is the lived reality of the clinical encounter, the subtle discrimination, the lack of cultural competence, the feeling of not being heard that explains why.
It's true that the clinical encounter is vital, and I can see that qualitative barriers like language and implicit bias play a massive role in whether a patient trusts their doctor enough to take a prescribed medication. But again, how do we systematically address a lack of trust without data? We only know about these elevated quitting rates because register-based data from health insurance companies allowed researchers to build large cohorts and identify the disparity in the first place.
Yes, the data highlighted the problem.
Exactly. Without that data, the medical establishment would simply assume everyone is taking their medication at the exact same rate. They would assume the system is working perfectly. My point is not that a database magically solves racism in the exam room. My point is that data makes the invisible visible. When we dismantle the colonial aphasia in our databases, when we stop grouping everyone under useless umbrella terms like migration background, and start tracking specific ethnic and generational health outcomes, we force the entire medical system to acknowledge the problem.
Acknowledge it, yes. Fix it, maybe not.
It's the first required step. We move from anecdotal complaints, which are easily dismissed by institutions, to undeniable empirical evidence. This is what enables policymakers to direct funding toward culturally competent care, professional interpreters, and specialized community outreach programs. Data is the lever that moves the funding.
I don't disagree that beta makes the invisible visible to the state. It certainly gives advocates a tool to demand funding. But we have to remember that this crisis is already entirely visible to the people living it. The Afro-Dutch communities, the African migrants, the Caribbean diaspora, they don't need a new database to tell them they are stressed. They don't need a study to tell them that their parents and grandparents are suffering from strokes and heart attacks at alarming rates. They live it every single day.
Of course they do, but the institutions need the proof to act.
But the danger of over-relying on data reform is that it gives institutions a very convenient excuse to defer real action. They can say, oh, we need to study this more, or we need to refine our demographic categories for another 5 years, while the underlying race evasiveness of the society goes completely unchallenged.
But without the data, they don't even say we need to study this more. They just say there is no problem.
True. But protection has to mean more than just successfully identifying a high-risk group on a spreadsheet. It requires an active dismantling of the neo-racism that categorizes these communities as others in the first place. It requires the medical establishment to recognize that a clinical encounter is not just a scientific exchange, it is a social encounter, fraught with power dynamics and historical weight. If we don't empower community social capital, if we don't support those safe spaces Ariana Rose talked about, and if we don't fundamentally transform how healthcare providers are educated to interact with these communities on a profoundly human level, then the most accurate data in the world is useless. It will only serve to perfectly, precisely document a continuing tragedy.
This brings us to a crucial point of reflection for today's discussion. As we summarize our positions, I maintain that protecting the fundamentally requires a revolution in our data infrastructures. We absolutely must dismantle the technologically mediated racialization that obscures colonial history and specific acute health risks. By insisting on accurate, non-racializing data that captures the nuanced interplay of environmental stress in biology, we take the crucial first step. We ensure early screening mandates, we change national clinical guidelines, and we build systemic empirical protections against silent killers like cardiovascular disease. You cannot fix what you refuse to measure.
And I maintain that while data is undoubtedly a necessary tool, it cannot heal a healthcare system built on a foundation of race evasiveness. True protection requires a cultural and institutional reckoning with the lived, everyday realities of discrimination. It requires the medical field to deeply understand that chronic stress is a biological toxin produced by social exclusion. To truly protect these communities, we have to go beyond the numbers. We must empower their social capital, support their community spaces for healing, and fundamentally transform the cultural competence, the empathy, and the listening skills of the healthcare providers who interact with them.
Despite our different frameworks on how to tackle the root of the problem, it is clear we converge on a vital, urgent reality. The current gap between national optimistic statistics and the severe health reality on the ground leaves Black communities in the Netherlands highly vulnerable. We are witnessing preventable, silent cardiovascular and mental health crises unfold in real time.
We are. And it is evident that addressing this crisis is going to require both the systemic, rigorous data reform you advocate for and the profound cultural shift in recognizing and validating lived experiences that I believe is essential to actual healing. The numbers and the narratives must finally align.
Survival is not enough. Protection requires systems that listen to communities, recognize stress early, and respond before silent risks become lifelong disease.